Welcome to our clinical explainer on polycythemia. This is really designed to be a high-yield review, perfect for you, whether you're a practicing clinician wanting a refresher or you're deep in exam prep. We're going to break down everything you need to know.
Now, before we jump in, I absolutely want to credit Dr. Mohammed Al-Nagi Mohammed. His comprehensive work is the foundation for this entire guide, and we're so grateful for it.
Okay, so here's our game plan. We'll start with the fundamentals. What even is polycythemia? Then, we'll zoom in on polycythemia vera, hitting the key clinical features. After that, we'll walk through exactly how to diagnose it using modern criteria, and we'll wrap up with treatment and prognosis. All right, let's dive right in. So imagine a patient's lab results come back, and they've got a high red cell count. The very first question we have to ask ourselves is, are we dealing with a true increase in red blood cells, or is something else going on here? And this distinction is absolutely fundamental. So on one side, you have relative polycythemia. Think of this as a concentration issue. The number of red cells hasn't actually increased, but the liquid part of the blood, the plasma, is low, maybe because the patient is dehydrated. It just looks like there are more red cells. But on the other side, you have true polycythemia. And here, the body's total red cell mass is genuinely elevated. This is the real deal, and it's where we find our primary and secondary causes. So, speaking of secondary causes, let's break those down. These are all conditions that basically send a signal to the bone marrow to ramp up red cell production. This signal is a hormone called erythropoietin, or EPO. Sometimes it's a totally normal physiological response to low oxygen, like in someone with COPD or living at high altitude. But other times it's pathological. You've got a tumor, like a hypernephroma or a hepatoma, that's just pumping out EPO when it shouldn't be.
Okay, so we've covered the secondary causes. Now let's pivot to the main event, the primary cause, and the one that is a classic for your exams, polycythemia vera, or PRV. With PRV, the problem isn't some outside signal. The problem is coming from inside the house, right from the bone marrow itself.
So what exactly is PRV? Well, it's a type of myeloproliferative disorder. That's a fancy way of saying the blood cell factory in the bone marrow has gone rogue. A single stem cell starts cloning itself uncontrollably, leading to this massive overproduction of red cells, and often you'll see high white cells and platelets too. The real game changer in understanding all of this was the discovery of a specific mutation in a gene called JAK2. This is the key. It's present in about 95% of all PRV patients.
Clinically, there are some classic telltale signs to look for. All those extra red cells make the blood thick, almost like sludge. That's hyperviscosity. And that can lead to serious problems like blood clots, both arterial and venous, and hypertension. An enlarged spleen or splenomegaly is also really common. But for exam purposes, the one symptom you have to burn into your memory is aquagenic pruritus. It's this bizarre, intense itching that patients get right after a hot bath or shower. It's a classic clue for PRV. So now that we know what to look for, how do we actually lock in the diagnosis? Well, thanks to that discovery of the JAK2 mutation, the whole diagnostic pathway has become much more streamlined and precise. Let's walk through it. If you're following the latest guidelines, like those from the British Committee for Standards in Hematology, the workup is very direct. You start with the basics, of course, a full blood count and a film to confirm the high numbers. But step 2 is the pivotal one. You go straight to testing for the JAK2 mutation. The other tests are still really important for ruling out other causes and just getting that complete clinical picture. And look how straightforward this makes it for most patients. If you have a high hematocrit, that's criterion A1, and you have a positive test for the JAK2 mutation, criterion A2, that's it. You have a diagnosis of polycythemia vera. It is that definitive in roughly 95% of cases. Okay, but what about that other 5% of patients, the ones who are JAK2 negative? This is where things get a bit more involved. You have to build a case, really, using a specific combination of major A criteria and minor B criteria. You absolutely need to meet the first 3 A criteria: a confirmed high red cell mass, a negative JAK2 test, and no secondary cause. Then, on top of that, you need to add either one more major A criterion, like a palpable spleen, or 2 of the minor B criteria, like high platelets or a really low serum EPO level, to finally lock in that diagnosis.
All right, we are in the home stretch now. We've talked about what PRV is and how to diagnose it, so let's wrap this up by looking at how we manage the condition and what the long-term outlook is for these patients. So, when it comes to management, we have 2 main goals. Goal number 1, reduce the risk of those dangerous blood clots. For that, we usually use low-dose aspirin. Goal number 2, get that hematocrit down to reduce blood viscosity.
The first-line treatment here is venesection, which is just therapeutic phlebotomy. Now, for patients we consider higher risk, maybe they're older or have a history of thrombosis, we often add in chemotherapy, like hydroxyurea.
And what does the future look like for a patient with PRV? This chart gives us a pretty clear breakdown. The good news is that with the right management, the majority of patients, about 70%, can live with a stable, managed disease. However, we have to be vigilant about two key long-term risks. About 15% of patients will eventually progress to myelofibrosis, which is scarring of the bone marrow, and another 15% face the risk of their disease transforming into acute leukemia.
And that brings us to our final thought. This isn't a condition you diagnose once and then forget about. It's a lifelong journey for the patient. So the question to leave you with is this. Considering all those risks, thrombosis, myelofibrosis, leukemia, what is the single most critical element of long-term patient follow-up? It's something to really reflect on as you apply this knowledge in your practice.